Bonjour. I appreciate the opportunity to speak this morning briefly to introduce the topic of heart and lung transplantation. As the former president of the United Network for Organ Sharing and an active heart and lung transplant surgeon over the past 25 years, I've been fortunate to participate in a number of outstanding programs in the United States, and I look forward to sharing my experience with you today. I do apologize. I do not speak Portuguese, and so indulge me in the translation, I hope, of the information as I share with you. As you know, almost 46 years ago to this week, the first human heart transplant was performed by Christian Barnard in South Africa. And it was the sign that heart transplantation, the perfect replacement, anatomic replacement of the human heart, could be accomplished. The technical pursuit was the first step in a long line of innovative steps to make heart transplantation a success. This is a picture of patients that I have transplanted early in my career, and what it shows to you is not only that the technical aspect can be performed successfully, but rather it can provide extraordinary opportunities for patients to survive with advanced heart failure and live well, with an extended quality of life which is extraordinary. In the picture you see no wheelchairs, no oxygen, no debilitating limitations. They are active, living patients, as many of you know, can restore their lives in the future. Congestive heart failure is a epidemiologic potential challenge for all of us. 5 million Americans and over 15 to 20 million worldwide suffer from heart failure. Close to 500,000 to 1 million new cases are diagnosed yearly in the United States. Many of these are men and women with a history of high blood pressure as a predisposing factor to heart failure. It has huge economic impact, not only in the diagnosis and the treatment, including things like heart transplantation, mechanical devices, pacers, defibrillators, and a variety of other therapies, pharmacologic, in order to help treat patients with advanced heart failure. The classic scenario is that the human heart changes in its normal geometry from a football to a basketball, having globular dysfunction and a lack of systolic squeeze or systolic function and diastolic function. To give you a picture is worth 1,000 words. This is a cardiac MRI of a patient that we transplanted after mechanical circulatory support. And what you see is that the ventricle is distended. It has ventricular hypertrophy. The right ventricle is good, but the left ventricle does not move blood. And you see the build and swelling of blood and potential coagulation at the apex. This is the kind of patient we commonly see both here and in the United States, and they require advanced therapies. So heart transplantation has evolved along with mechanical devices in the United States, and I know that you're on the cusp of developing mechanical device technologies here. I'll share just a little bit with you. The biggest challenge since 1981 has been, even though we can do heart transplants, not every patient who needs heart transplant can receive one. If you look at the International Society of Heart and Lung Transplant data, it shows that only about 3,700 patients receive heart transplants worldwide. And still, there are many patients who would benefit from it if we could figure out how to provide them with a transplant organ. The challenge then is that the lack of organs for transplantation limits our ability to save lives and improve lives. And so the demand clearly outstrips the supply. Some of the solutions in the United States, and I think we've explored here during this week, including optimizing the donor management and policies and legislative procedures to improve organ donation. As well, we've been asked to extend the donor pool to take those who are not ideal, but rather could be managed to be better donors and hopefully save lives. As you see, standardization of donor protocols and management, resuscitation of suboptimal donors, even transplanting high-risk donors, and protocols for donation after cardiac death. Desensitization and other strategies are being employed in other discussions this week. There are a number of ways in which we learn from our colleagues in kidney transplantation using systems that actually perfuse the organs for a period of time to allow them to accommodate, to improve, so they're not subject to ischemia and reperfusion. This has been tried for heart, and in fact, could potentially, I don't know if this slide's going to, and lung transplantation shares a place in heart and lung failure that we are trying to explore as well. So the challenge in lung transplantation, in the same way that hearts do not have enough donors, is donor availability being the critical limitation to expanding criteria for lung transplantation in North America and here. We have to balance the severity of the patient's illness, and often we have to make choices which are not ideal to help patients with end-stage cardiopulmonary failure. There are a number of programs that have looked at using high-risk lung donors using the ex vivo perfusion system that's been developed in Toronto. And this is a report from the New England Journal of Medicine that looked at expanding lung transplantation in the United States using suboptimal donors. They reported on the Toronto technique of perfusing the lung out of the body, resuscitating it, improving its characteristics, and then transplanting it into a patient. They reported 20 high-risk donors that were not suitable for transplant initially, and then were resuscitated outside the body, perfused, treated metabolically, and then transplanted. And it was an extraordinary outcomes, equivalent outcomes at 30 days in terms of mortality, critical care impact, and ultimate patient survival. So this technology will change the face of lung transplantation and may be available to you here in the near future. How does the system work? It takes the lungs and perfuses them on a circuit, gives them oxygen and blood, removes fluid, and allows them to be ventilated in a gentle fashion. And ultimately, the video won't show, but it shows these lungs expanding and contracting as they are resuscitated. And they can be placed in this circuit for up to 12 hours. It's remarkable to see this. I actually had the chance to go to Toronto with Dr. Shafkashevsky to review this transplant procedure. And I'll tell you how this will change the face of transplantation. So this ex vivo lung perfusion allowed us to take a lung from Chicago in a patient that was not suitable for transplant at the time. We flew from Chicago to Toronto, put the lung on the circuit. It was improved in its hemodynamics, its oxygen carrying capacity, and then we flew back to Chicago and transplanted the patient. Here's a picture of the ex vivo perfusion system. It takes the oxygen, provides it, and then allows you this kind of success. This could solve many problems in places like Brazil in terms of lung transplant going forward. You might ask who in the United States gets a lung transplant. It's probably similar to here. Patients with chronic obstructive pulmonary disease are the most common. Those patients with idiopathic pulmonary fibrosis and a variety of other diagnoses as you see here. The international lung transplant experience continues to grow as well. In the United States, about 2,000 people receive lung transplants each year, many fewer than would benefit from that therapy going forward. And you see the international experience is continuing to grow as we improve in our lung transplant program. We've also developed a sophisticated scoring system to help judge who is the sickest person in need of a lung transplant. This lung allocation score goes from 1 to 100 and judges the severity of the patient's illness and the urgency with which we would transplant them. And the score tries to predict who is likely to die while waiting for a lung transplant, as well as who is likely to survive and do well after lung transplantation. And the score is filled out on every transplant recipient in the United States. And based upon that information, a lung is then allocated to them with the greatest risk of dying and the greatest potential benefit. So the lung allocation score has changed our ability to allocate lungs effectively. So the difficult challenge then in patients with heart failure who need a heart transplant, but there is no heart available, is what do we do? And so we have to either wait for them to develop organ failure and potential death, 50% of them die within 1 year, versus using a mechanical device which we have available to us. Probably the most significant or high-profile occurrence was the Vice President of the United States who developed heart failure, and he underwent a number of heart operations and ultimately had a mechanical assist device, Heartmate 2 device. And this device then allowed him to survive and do well. And so the question is whether the mechanical devices will be better or different than heart transplant. And I explore here just some of the potential advantages of the mechanical device. They have no rejection. They have no immunosuppression needs. They may not have the same complications of steroids after transplant. They have few failures. They may be able to actually resume full active life, and they don't have to wait for a heart on the transplant list. It does not exclude them from transplant consideration. So they still can get a Heartmate 2 and be a candidate for transplant. What are the problems with mechanical devices? Well, they can develop driveline infections. They can have hemolysis or strokes. They may need anticoagulation indefinitely. We don't know exactly how long these devices can last, and they can't go swimming. There are some lifestyle limitations. And they need someone with them all the time. We don't know what their battery life, extended life will be, but it's usually between 4 and 6 hours on the battery. So at the Ohio State, we have a large program of mechanical circulatory support. We use the Heartmate pump. The Heartmate 2 has a rotor that spins and ejects the blood. It is placed in the left ventricular apex and ejects the blood into the ascending aorta. It has a single drive line that goes to a controller and batteries. And these batteries can last 4 to 6 hours away from the plug. Here's a picture of the patient with the pump in place, and you see that it's about the size of a D battery. At the Ohio State, we have over 90 patients on mechanical pumps. Many of them are males with heart attacks. Most of them are in permanently, 72% are destination therapy, and about a third of them receive transplants after the pump. We've replaced a number of these pumps, so this will be an extraordinary piece. So while this is a picture of a patient waiting for a heart transplant, you see she is active. Her husband is at her side, she's on batteries, and is doing very, very well. She subsequently went on to get a heart transplant. And the mechanical device allows the patient to improve their overall cardiovascular function and be quite successful in heart transplantation. So Dick Cheney, in the same way, went 20 months, and then he got a heart transplant. And so this captured the imagination of the community to say, these pumps can work. After transplantation, many of our patients succeed, as you know, 82% 1-year survival, 70% 5-year survival, and many patients live for many, many years, as long as 25 years. The world record heart transplant recipient that I'm aware of was 29 years after transplant, 31 years after. But he died from cancer, unrelated to his heart failure. So transplantation can be a good long-term solution. But the question we may ask today, and I'll end with this, can the LVAD outlive a transplant? This is a picture of a patient that we put a mechanical device in who had heart failure. She was a woman who had a 52-year-old woman with breast cancer, had treatment for her cancer, and was a complete cure. But she developed heart failure after chemotherapy. And so we put the mechanical device in to try to save her life with advanced heart failure, and we put it in 2005. This is a picture of her 2 months ago. She has had the pump in for 8 years. without a problem, and she does not want a transplant. So, we know that the long-term results with the mechanical devices can be quite good compared to medical therapy. And so I close with the idea that these pumps will be smaller. The Heartware pump is now the size of, fits in the palm of your hand. It's smaller, it's easier to manage, it is very, very effective, and it may allow us to transplant patients who were too sick before they got a transplant. So, in conclusion, I think the key to success in the evolving development of heart and lung transplantation in the United States is matching the recipient's needs with the ability to serve them with a mechanical device. Transplantation is still the gold standard for survival and quality of life, and donor availability, unfortunately, as you've heard much of the conversation today, is the rate-limiting step. Transplantation is also a resource-intensive therapy. Newer generation LVADs may provide some advantages. They're smaller, they may be more efficient, they may allow patients to resume a normal life, and ultimately, they will help us extend the ability to save lives with heart failure. With that, I'll say thank you very much, and obrigado.